Welcome back to another PCBH Corner, and while my mind has a specific topic to go over, my mind was thinking maybe we could just have a free-flowing one about any things that have been going on in clinic lately, or any awarenesses that you had. The one I wanted to talk, and maybe this will be the jumping off point, is that we had some interesting data that came out regarding our patient engagement and patient satisfaction. I think we sent some things on the listserv or CFHA about those scores, but it was a really interesting data set that came out about our patients' experience with our BHCs as far as provider listening, provider time spent, provider explanation of care, and then provider knowledge of health history that I wanted to get into real quick. Before that, though, is there any other topics that your mind's going to? It's like this would be a cool thing to kind of like go over or to review. It's been on my mind thinking about it a little bit more.
Based on what's been going on in clinic?
Anything that you've been reading, anything recent?
I mean, I think the biggest one for me is just the importance of that warm handoff process. And then, and I know we've done tons of videos on that, and it gets into all kinds of questions regarding, you know, the ratios of PCPs and BHCs, which we have done a video on. We've done videos on these things, but I guess it just really hit me.
When did it hit you?
What was that?
When did it hit you about the ratios?
I don't. Yeah.
I know when it hit me this past week when we had to deal with some things that came up, and I really like this idea of, and maybe we can expand on that. Maybe let's start with that right now about where your mind was going with ratios, because I know part of what I made a snippet about this when we were coming up with our templates for next year. We also had some things that we had to scramble this week about, like, oh man, ratios aren't where we want them to be. What does that ripple out to? So yeah, where's your mind going with ratios?
I mean, all of the above, and I think that it was, you know, you asked me when did it hit you. I think it was when we were answering an email related to the video that you had put out. And then I kind of started thinking about it, and in our system, we're constantly saying who or die, which I know, that sounds really intense. And
Grace, love, and compassion.
And I'm actually going to give credit to Dr. Ruth Ulmer for that one.
I know, right? We're not going to own that one. We're not going to say, hey, that was us. Yeah.
We're going to give her credit for that. AK.
Do we have it up on our walls in our office? Yeah, we do, but that's okay. Yeah.
And in our system, I'm not going to say that who or die is easy to do, because it never is. No matter how many BHCs you have, depending on how things land, if everyone's coming in right at one time, you could have 10 BHCs, but if there's
11 handoffs.
11 handoffs, or the first 10 are starting their visit like right then and there. But I was thinking about that who or die, and how in our system, you know, that is something that we have to explain to our interns and everything. And it can be a little bit of a difficult concept to get folks to buy into, like a little bit, you know, and really good questions. Well, what do I do if this happens? And what do I do if that happens? And that's in our system where we've had to work up to it. You know, if you watch our Instagram versus reality, we've worked up to it.
We forget about it a lot, yeah.
And if you're in a system with your ratios being 1 to 4, 1 to 5 and up, and that's if you're lucky that it's 1 to 4 or 1 to 5 and up, a lot of times it's 1 to 8, 1 to 9. And we're saying, hey, come in with this who or die mentality, or never let a handoff, and the power of handoffs and how important they are. And at the same time, I don't know how feasible some of this is. So I guess I just was having so much empathy for systems that are just getting started.
You know, I'm glad you said it. There has been moments, Bridget and I, we oftentimes will go through like identity crises and just different things. It's like, there's sometimes my mind gets worried about selling something that isn't possible and isn't realistic. And the other thing I think that comes up as well is just how much we take for granted those things about having so many BHCs. And this past week when we had some moments where we had to scramble a little bit, you know, it's like, oh my gosh, just one BHC is going to be by themselves. What are we going to do? Who can cover? And we had our team does what our team does, and they step up and they provide coverage. But it's just one of those moments of recognizing it's like our system really has uptaken to a point where it's not an option not to have the ratios that way. Not only from like the sanity of the BHCs that are working in the clinic if the ratios get to a certain point, but literally the PCPs have this expectation of like, no, there's going to be availability for BHCs to be on. And so I think that is, I don't know where my mind's going with that. It's just that awareness that has been sticking with me lately. It's like, it's a cool thing that our system can do. And it's a tough thing, I think, when we talk about these things.
And the quality of warm handoffs are so much better when PCPs know they can count on there being BHCs available. So they're going to be able to get BHCs for a lower threshold situation. And I know we've talked about that before, but when your ratios are so big or so small, depending on how you want to look at it, so many PCPs with so few BHCs, including possibly even one, PCPs, they're going to save them up. I think that we did the corner with Dr. Stedman where she kind of like spelled that out.
Yeah.
And so I just have so much empathy for if you're brand new or you're one of two. And maybe even if you're one of two, that doesn't always mean that y'all are going to be in clinic together, because folks have to take CEU. They got to take paid time off. Maybe there's a little bit of paperwork time, or maybe there's a couple different things that they're doing with their role. So even if there's two BHCs and there's always somebody available, you might be riding solo a lot. And if you're a PCP, are you really going to get a pre-diabetes? Are you really going to go and dig a little bit further where you think, you know what, I think there might be something going on that with this stress that's fueling this blood pressure. If I'm a PCP in a system and there's me and 8 other PCPs, I have one BHC, am I going to open up that can of worms? Or even like ask certain questions to see, hey, would you want to meet with a BHC?
You know, my mind's having this moment right now listening to your talk, as it always does, like this profound, and we talk about this, but maybe like very much overtly saying it, just like we tell our BHCs and trainees, when you're doing interventions with patients, they need to be contextual. Like you can't ask someone to do something that doesn't make sense. Almost a reminder is us as consultants or directors or people that are setting up clinics and organizations, and when we're doing presentations and talking about this, like don't tell people to do stuff that doesn't make sense for people to do. And and it needs to be contextual. And you know, when we go into systems, I think early on when we were consulting, we would just kind of indiscriminately say, this is what you need to do. Without looking at the system of how many BHCs are there, their skill level, training them up, where it becomes very nuanced. It's a lot more nuance over conversation.
It's so nuanced. And that's why we made that the recent video about my system isn't ready for full integration. Now what? And we go through and we delineate multiple different strategies that somebody can do to make themselves more available or accessible, to be able to reach more patients, and to be able to get started right away. And those are all great, but that isn't going to bring your ratios. That's not going to necessarily always translate into you getting these handoffs that you kind of maybe promised during the job.
Sold, dare we say?
During the job description. So, I mean, and we had to start at many different places looking at different clinics from scratch, a couple of them, and you do have to build the ship while you're.
And I think that was the other profound moment that I was having this past week. Obviously we've had a really great and incredible 2 months to start 2024 of January and February, hitting the 2 most productive months ever, hitting the visits per day average, the highest that it's ever been. And there's a moment, a lot of gratitude, and there's a moment of a lot of awness, like incredible about how much this almost seems like there's a tipping point now that this is so uptaken, this is so done. And it didn't happen overnight, and oftentimes our minds, as we generally do, we forget about all these different things that had to take place to get to this point. And it's still a struggle at times, I think that's the thing that my mind was really leaving this week kind of with a profound awness with, was one, just what the team has done, the embracement of PCBH within our clinics. Obviously the data, we'll get to this a little bit about the patient engagement and satisfaction with the survey. And then also this recognizing it's like there was a lot that went into this. This wasn't done overnight.
And I had one more comment on that. It was just thinking about how each and every member of our team was at that time the missing puzzle piece.
It's so incredible, right?
And then we get that rolling, and then it's like then another big piece becomes apparent, and we're like, we need a few more puzzle pieces. Like we can't do what we want to do if we aren't taking care of our current BHCs, and we aren't making this a great place to work so that we can continue to get more BHCs, because we can't do the vision that I know that you and I want, which is making such a huge difference in the health of our community. We can't do that if we don't have the people power. So at this point, I would say the thing that keeps me up the most at night is making sure we have enough people to do this.
And
do this work.
That's a cool moment of also recognizing, and I know oftentimes in the listserv it is a lot about recruitment, which makes sense. And I think a lot of, because programs are new, they're trying to grow, they're trying to expand. Obviously the Great Resignation that we had that kind of really plagued healthcare in a lot of different ways. It is interesting to see us now. It's like, it's not so much recruitment anymore. Now it's like retention. We have this thing that's kind of almost now alive and kind of on its own right now.
Yeah.
It's like, it's not control.
It's taken on a life of its own.
That's what I was. I was trying to come up with that saying. I was like, that's not right. But it's taken on a life its own. And now again, there's expectations of like, hey, now, and we don't talk about that a lot as like directors. What happens when your program does mature enough to a point where it has taken a life on its own? Now it's like a different feeling. It's like, oh God, it's not so much about recruitment, which it still is. Now it's about retention. Like, we need to retain people in this job. How can we make sure the job is fulfilling and joyful and engaging? How can we make sure that that's a part that we're focusing on?
And if folks have a training program, if folks don't have a training program, I recommend getting one.
Yeah.
And then if you do, that's one of the best ways of having that recruitment that's built in, is because you're making an environment to where it's challenging. I mean, nobody on our team, if you ask folks on our team, nobody's going to say it's an easy job.
No.
But it's challenging and it's meaningful, which again,
it's inspiring.
Right. And going back to employee engagement numbers, that's what folks are looking for. They're looking for things to be challenging. They're not necessarily looking for things, to be easy. So how do we continue to make that environment while upskilling and doing it at a developmentally appropriate pace, which is always going to be something that's difficult for us, is because we're like, we bring folks into our system and we're like, all right, now go do everything. And
be somebody.
And then of course we stop ourselves. There's all these checks and balances, and we make sure no, we're going at the appropriate developmental level.
I think the thing that was cool about what you said about the training program, and not only is that a great way for recruitment, it's a great way for retention too. And I think you were saying this because people feel inspired about teaching and training future generations, and how much, I would say, what has led to our exponential growth unquestionably has been the training program, and not just the direct obvious thing. It's like, we've been able to recruit a lot of people. It's because people now, I like training. I like that being part of my job that I can do.
Yeah, that task diversity that helps against the burnout.
Good word. Yeah.
And then they could be doing something different for a small period of time. And as we've done in our system, because we're a training program all the way around, including the family medicine residency, instead of just taking a 1.0 or a 2.0 based on how big we are now, BHC, and having them be the behavioral scientist and having other folks be clinical, what we did was we sliced and diced that. I don't even know how many we're up to, because everybody's getting 10% time. That's some type of educational, and sometimes it's within the BHC training program, sometimes it's within the residency, and sometimes it's with both.
And without question, while the primary value is still clinical and still serving patients, that it's a healing and respite that people get to have.
Yeah.
So let me ask you this. The reason why I was bringing this up was, and I guess it goes along with like the handoffs and the mindset that you're having, is our recent patient satisfaction and patient engagement scores that really came out. And, as a reminder, our minds predict this is largely becoming a normal part or an expected part of healthcare, that you're having some sort of patient satisfaction, patient engagement scores. And then one thing that we have a benefit of is the organization that we partner with to get our patient satisfaction engagement scores. They give us comparisons about other community health centers within the state of Washington, and then within the region.
That's so helpful.
It's so helpful. And let me ask you, why does that become helpful? Why do we say that that's helpful?
Having the comparison.
Yeah,
because it could be a situation where might be a ceiling effect happening, where many people find that their behavioral health provider listens really well and is very supportive. And so you want to make sure, so if you get back, your score was a 90. Well, 90 sounds really good. But what if...
What does that mean?
Yeah, and what if on a state or regional level, that 90 puts you in like the 10th percentile?
Exactly.
And so being able to make sure yourselves and your system compared to what patients are saying about their providers, behavioral health providers, in other systems, gives you
puts the number,
a reference.
It puts a number in context,
Yeah,
right?
absolutely.
Like while we can go, and I really like how you said that, 90 out of 100 of a composite score, that sounds pretty good, right? It's like, hey, that's maybe an A minus, that sounds great. We really don't know what that means, though. We have no idea if that's a comparison, if that's good, if that's bad. And I think that's where, my mind has been thinking a lot more about, single session mindset and a moment at a time mindset, which is what our team, not only embracing that primary care behavioral health mindset, our team does embrace this moment at a time mindset. And we've done videos about that, so we won't go into necessarily what the philosophy is. What's interesting is our patient satisfaction and engagement data is really showing us, compared to other health systems, one, probably aren't doing PCBH. I think we can safely say that they'll probably do more co-located traditional therapy. Two, safely we could say, are not approaching it from a moment at a time. And when we make those comparisons, where our program is being ranked, and especially the one that's still my mind can't wrap my head around, is that perceived provider time spent.
Right.
Where, what was the data that we had? 76 of our visits are between 16 and 37 minutes. That perceived provider time spent is in the top 1% of both state and regional comparisons.
Yeah, I think it was just mind-blowing that, I guess anecdotally, when your system is up and running and you've been a BHC for a decade like Dave and I have been, you see how helpful this can be. You do just a little bit. You ask somebody a little bit about their life and you come up with one or two things, maybe in many cases one thing they're going to try. And they're like, oh man, Dr. Beachy, this was so helpful. And although I thought it was helpful, I was like, really? Like,
you sure?
Like,
yeah.
Are you sure? Because, compared to maybe the way we were trained and all these millions of things were going to have to happen, when I really just was interested in them, took into account where they were coming from, and then filtered the evidence-based, science through that filter, seeing things through their lens, threw out a couple of things where in many cases they already throw it out. And I'm like, oh, hey, we already got our idea. Do we want to say we're going to do this 3 times a week? And they're like, yeah. And we're like, all right, we got our plan. I guess I knew that it was working based on the people coming back, people saying that they enjoyed it. All the
anecdotally, we knew that it was working.
But to see on those metrics that come out of top 1 percentile on provider listening, and then provider satisfaction with provider time spent, I think was in the
top 1%.
So maybe the provider listening was at the top 94th percentile.
That's why I was thinking it was top 10% at the very least.
It was definitely in the 90s. The point being, folks liked the service and they felt like they had enough time. And then when we go to that data, when you found that way in Ocean to be able to look at things and found 76%. So 3 out of every 4 of our visits is between that 16 and 37 minute mark. Some a little bit shorter and then some a little bit longer. To get that type of results,
it really starts to make you challenge our assumptions about patient experience and what they're expecting and also what they're wanting and what they deem helpful. And,
I know.
And it's an interesting thing too, because I was talking about this with our trainees this past week. It also becomes interesting, the skill set and the knowledge base about how to frame these moments and really give the expectation this is going to be meaningful. We were talking about this as a training group, that you could go into a room in a visit and say, we only have 15 minutes.
Oh yeah.
And immediately, now the perception is already created. I remember Bob Rosenbaum talking about this, right? That our perception is largely built off of the other person that we're interacting with. So if I have someone that comes into the room, say you're the BHC, I'm the patient, you tell me, hey Dave, it's great to meet you. We really only have 15 minutes. Immediately,
sorry I can't spend more time with you today. I've been just so swamped and so busy.
It's not traditional therapy. We don't do that here.
If you want that type of help, you're going to probably want to put in a referral. Already
me as a human is noticing, oh, you're not really kind of sold on this, versus someone coming in and our one postdoc, Shanice, she did such a great job. It's like, hey, we have 15 minutes. We're gonna get to the good stuff. And the not only the language, the actual language that she said and used, the words that she used, the excitement that you could have through her voice, that I am excited to get to know you right now.
What I started doing when we're getting, blasted with handoffs, and of course we have who or die situation. is I go in and I mean it. So it works because it's sincere. It wouldn't work if
you're just making that up, right? If you don't believe it, don't do that, right?
If it's not. But I say, yeah, we've been super busy today. It's really cool. I think we have a good 10, 15 minutes for me to ask you a few questions, get to know you, and come up with at least something you're going to try. And it might be something you're already doing, but let's get into it and see what we come up with.
Let's see what happens, right?
Yeah.
And again, it's the way you just said that there, and I'm sure other people that were watching this picked this up. It wasn't just a language that you used; it was how you said it, how your voice was, the excitement of that. And that's the thing that really has been, my mind has been thinking about a lot when we got in this patient satisfaction engagement. It's like, what is leading to that? What is leading to our patients clearly versus a traditional mental health approach are technically. Well, I don't know. That actually probably might not be true because I was going to say they're technically getting less minutes and time with care. I don't know. That may or may not be true. Just it really does challenge our traditional thinking about what patients want and what the outcomes of these things would be. And I think it really does get down to our team does such a good job of not underselling what they're doing. They're almost hyping it up. They believe in what can be done in that moment. Yeah.
I know. It's just like making me think about we're not researchers as our main gig, but yeah, I don't think it'd be very hard to have something set up where people came in and had some type of we only have 15 minutes together. I'm so busy versus this is so great. Even though we've been so busy, we're going to be able to get a good 15 minutes together. That would just be interesting.
And maybe that's something we can end, unless there's other things you wanted to, anything else you might want to go to. Maybe that's something to end with for you all, if you're watching this, thinking about maybe talking with, talking to yourself or talking with your team about how they're setting up visits to promote an expectation that this is going to be not only a moment, but a powerful moment. And the one thing I was going to say that when you were giving that example before about that patient interaction, the way you framed it, it reminds me again of Bob talking about these moments that last forever, right? There's no, time is not relevant anymore within that moment because you create it in a way that there's connection, there's humanity, there's love, there's compassion, there's curiosity. When you have all that stuff, what was that quote that we said the one time? Curiosity plus, I think, the contextual interview. Time doesn't exist in those moments. It's filled with infinite space then that we could decide of what that is, which I'm sure does lead to patients being like, oh, that was a good moment. That was a really good connection moment.
And because I know exactly what you mean because, you and I, even off camera, we talk about this stuff.
What?
All the time. Is there, in layman's terms, a way to describe what you just meant by at the very end? So for any of our viewers who watched to the very end and then they heard you say time wasn't real in that moment. The moment was infinite. It was lasted forever. Of what they could be looking for, or what do you mean by that?
The best analogy that I have, and I don't take me off of this tangent if I go there, is flow.
Okay.
So there's a lot of research that's out there about the phenomenon of flow that people get into. And one of the core aspects of flow that's often described is that things seem to slow down. Either time just doesn't exist anymore, or the perception of time isn't there, or just time significantly slows down. And I think when you start to promote services and PCBH through belief and passion, and then you get curious and you're learning about the human through the CI, and you come up with pragmatic goals that are reflective of the context, flow, I think, has a high probability of happening within those visits.
Right.
And that's what my mind perceives. We've talked about this before, and when we've been shadowed by other BHCs, I'm thinking about one intern that shadowed. We came out of the visit, she was with me, we came out of the visit, she's like, how long was that visit? The visit was probably 45 minutes, and we looked down at the thing in Ocean, it said 22 minutes. And the reason why is because curiosity was there, love was there. The CI
Sometimes I look down and it is 45.
I know, and that's a really good point. I almost feel that a lot of times, we've been here a hot minute.
But it's funny that you said that about the intern, because I have certain time with patients where all of a sudden we'll get into some really important stuff and we're in flow, and then you kind of have that natural breaking point where you're okay, I'm going to write down what we said we were going to do, and I look at the clock. And I'm dang. I always say something like this to patients. I'm we did so good. We got all that done in 21 minutes. And they're really? And I'm yeah, because we started, and sometimes I even say it back. I'm we started at 3:41, and it's 4:02 right now. Is that my math right on that? But yeah, it's 4:02 right now. I'm we got all that done in 21 minutes. And I'm damn, we did good today. And that, you see, and we have that,
what a beautiful,
we have that moment together.
What a beautiful way of not only reinforcing the moment and the connection that was happening, but how cool is it that a patient gets to feel like they came to the healthcare clinic and they did a good job?
Oh.
Right? Like they participated in that, right? Like,
that never happens, right?
Right.
Well, sometimes when you do good with a shot,
yeah,
like they come in, they do the shot, and you're like, oh, that wasn't so bad, and they're like, oh, you did so good, honey, and you're like, yes, like
I did great. That's right.
I did great. Like it feels good. It doesn't matter that we're like 40-year-old people, And
I think that goes back to some of the AIDIT principles of, AIDIT standing for acknowledge, introduce, duration, explanation, and a thank you. And it's just a way that helps prompt patient engagement as far as connecting and first introducing yourself to a patient. That thank you, though, at the end is almost like highlighting what that was. It's like, we got some shit done today. Like, thank you.
Yeah.
I'm inspired by this work. I go back to what you said though as well before. You got to believe it though, right? You can't fake it. You got to actually believe that this is actually occurring.
And that's why we just made the last video we did about the real reason that your integration maybe isn't taking off is if you're feeling, how we had said, like you can't feel gross while doing this work. Like if you're going into it and you're like, I don't believe this, I would say maybe just give it a try. Experiment. You know how we always say with patients, like experiment with this different thing. So if you're brand new and maybe you were hired as a traditional therapist and then it's been changed on you and now you're being forced to watch our videos.
Hey,
you're doing good out there. You're for it. Like just try it. Just try going in with that upbeat attitude. Just try thinking about what you can get done or trying to go for a moment versus trying to do everything. Because all it takes is a couple of really good patient visits where you start to believe and somebody says, hey, this is really helpful. Or somebody comes back that you didn't think could get, not that you didn't think they could get better, but you didn't think that the problem that they were coming in with would be big. This much improved from when they came back the next time. And they did. Try to conjure those images up in your mind and just see what you can get done, because you can't learn this stuff, I don't think. And I don't think you learn these different interventions if you're feeling gross about it. The patient's going to be able to feel if you feel gross about it, and the integration is probably going to fail.
Not to have this, we maybe should have just done the Jordan stanza and stuff. But the one thing that you said there that my mind, this is another thing we have been talking about more lately, because we're doing some trainings now. We have some trainings upcoming. I was just talking to a group last week about this too, about a training that we're going to be putting on. Really thinking about versus me just coming in and being like, hey, this is how many visits that we've done. This is the average number of visits per patient that we do. This is their patient experience and what they're saying, and almost like trying to like force them, wrestle them into believing, like, look at the data, look at the stats, like you can't deny this now, right? Like that doesn't work.
We know that.
We know
that facts don't change opinions.
Relational frames just get activated so much, right? So it's like, that's the other thing I've been thinking about too, is how can we train some of these aspects of PCBH, of a moment at a time, at a single session? How can we train it in a way and explain it in a way and do maybe some experiential kind of activities that allows it to start to make sense in the uptake versus what we see a lot of times where it just causes people to feel gross. It causes people to go against maybe what they believe their value is and being a helper within the setting. How can we do this? Maybe, and dare I say, I know it's corny as how to say, maybe how do we train these things in a more contextual and compassionate way that allows people to actually to hear it and to see it and to uptake it?
Well, I think that's the mission that we've been on.
Yeah.
For the last, I think it's been set in motion for several years, but I think very explicitly in our trainings for the last 2-3 years has been that awareness that, we're going to have facts and data, of course, but that's not going to be the main change agent. That might be part of it, but coming up with stories, experiential experiences, having that change of heart, and then being able to support data and different ways of doing things, step 1, step 2, that's going to be the magic combination, not do this because we said so.
Which goes back into our informed consent that we're being more about not only during our presentations, but when people reach out to us, because there's so many times, I think we've made this joke before on videos, there's so many times that people will be like, well, you know, we really want you to train our team in skills, and we just won't do that anymore, right? So it's like, no, like what we will do though is that we'll train them, really try to connect to their whys and moments and trying to, as you said, cultivate these things. So it's like, oh yeah, that was a moment that it challenged my expectation of what the patient was going to do. And then I think it still frustrates directors because I think they're like, yeah, but what about the skills and stuff? But it goes back to what we talk about with patients. It's like, I'm not going to indiscriminately give you skills that, one, are going to not work, that cause this person to be like, see, I knew it wasn't going to work. And then two, most likely more than them even applying the skill, they're going to be like, no, that doesn't feel good.
Yeah, so if you're ever watching anything by Beachy and Bauman here, and you're like, just say it, just tell us what to do, there is a reason behind that, I promise.
There's been too many of that, too much of that, too many of that. There's been too much of that, right? Of just trying to tell people what they do. All right, well, I don't know even what the title of this PCBH
I know,
is going to be.
you're going to have to come up with
No, you're the one who comes up with the titles. I'm not doing that.
Ramblings.
Maybe that will be some PCBH ramblings that we had on this beautiful Sunday day. So thank you as always. If you made it this far, stopping by. If you do have different thoughts and ideas for future videos, please let us know. We'll do our best. But
we probably won't do them. We'll probably just do a rambling.
Correct. That's always what these are. But thanks for stopping by.